Hello everyone, myself Lokeshwari from 1st MSc Microbiology, Secondary College, Tirupattur. Here we are going to see about Varicella zoster virus. The general properties of Varicella zoster virus are: it is otherwise known as human herpes virus and belongs to the family Herpes viridae, subfamily Alpha herpes virinae, genus Varicella virus. It is a DNA virus with a linear form and double stranded. The structural elements of Varicella zoster virus includes core genetic material, isohedral protein capsid, tegument, viral proteins and the enzymes, lipid envelope and the glycoprotein spikes. This is the structure of Varicella zoster virus. It consists of glycoprotein spikes, lipid envelope, tegument, nucleocapsid and a double-stranded DNA genome. Varicella zoster virus is a double-stranded DNA and an enveloped virus. The genome size ranges from 125 kilobase pairs long and short fragments with a total of 4 isomeric forms. It has only one single serotype. There is some interrelationship between herpes simplex virus and Varicella zoster virus. Next, replication. Attachment of the viral glycoprotein to the host receptor mediates the endocytosis of the virus which enter into the host cell. Fusion with the plasma membrane to release the core and the tegument protein into the host cytoplasm. Next, the viral genome is uncoated for the viral transcription and replication in the nucleoplasm. Incoming viral capsid gets disintegrated and only the DNA is released into nucleus. Three distinct classes of mRNA are alpha, beta and gamma. They regulate in a coordinate and cascade fashion. Alpha or immediate early genes contain the major transcriptional regulatory proteins. Beta proteins include the enzymes which are required for the replication of the viral genome, a DNA polymerase, single-stranded DNA binding protein and a set of enzymes which is involved in the DNA repair and deoxynucleotide metabolism. Viral transcription and DNA replication occur in the nucleus, in which the particle assembles and exists from the epithelial cells in the skin, causing a primary infection. This virion acquires its envelope by budding through the nuclear membrane. Then, the continued virion assembly and maturation in the secondary envelope, which is released from the cell. Next, pathogenesis of Varicella zoster virus. The portal of the entry of virus is via the inhalation of the respiratory droplets through the respiratory tract or also via the contact within the infected person. This virus infects the upper respiratory tract and the virus replicates, then proliferates in the regional lymph nodes. Then it follows the primary viremia in the bloodstream. From the bloodstream, the virus localizes in the skin, mucous membrane and other organs, particularly liver and spleen, which results in the secondary viremic stage. This stage is manifested by the appearance of the rashes which rapidly develop into fluid-filled vesicles. Within 3 days of infection, this fluid becomes cloudy with the influx of leukocytes, fibrinogen and interferons. The pustules then dry up, scabs form and they desquamate. Lesions and the vesicles are present in all the stages. Then after, the virus-affected host cells are cleared by the T-cell mediated immune mechanism and the antibody-dependent cell-mediated cytotoxicity. The virus may also enter nerve endings and transport to the dorsal root. After this infection, virus remains latent in the cranial nerve with the reactivation causing the immunized host disseminated zoster shingles. Transmission of Varicella zoster virus. Humans are the only reservoir of Varicella zoster virus. Infections caused by the Varicella zoster virus are highly contagious. It is because of the inhalation of the aerosolized respiratory droplets and the direct contact with the vesical fluid skin lesion patients. Next, pathophysiology of Varicella zoster virus. The primary infection caused by the Varicella zoster virus is chickenpox. It is transmitted through the aerosols and targets the mucoepithelial cell, then starts its replication. Then the viremia is a contagious and a febrile illness occurs. After the resolution, the viral particles remain in the dorsal root ganglia or other sensus ganglia. Then the host immune system suppresses the replication of the virus, which lays the dormant for years to decades in the latency period. Next, herpes zoster virus, shingles. Host immune system fails to contain the virus and it reactivates the Varicella zoster virus. Then it spreads down to the sensory nerve and causes skin rashes. Then inflammatory response in the sensory ganglia, which includes it involves the plasma cells and the T lymphocytes and also can result in the neuronal damage and neuropathic pain. Host risk factor of Varicella zoster virus are it mainly affects the pregnant women and the age factor include infants and elderly. Immunocompromised patients includes HIV, AIDS, organ transplantation, chemotherapy and chronic steroids. Clinical syndromes of Varicella zoster virus are it exhibits two distinct syndromes. They are chickenpox and shingles. The main clinical syndrome of Varicella zoster virus is chickenpox. It is characterized by the vesicular lesions in different stages. The primary infection with the Varicella zoster virus results in the varicella chickenpox. The different stages in the development of the face, trunk and extremities. The incubation period for varicella is 14 to 16 days after exposure to varicella or a herpes zoster rash with a range of 10 to 21 days. This rash is generalized and itchy. It progresses rapidly from the macules to papules on the vesicular lesions before crusting. This rash usually appears first on the head, chest and back, then spreads to the rest of the body. In case of children, the signs and symptoms are generally mild with an itchy rash, malaise and temperature up to 1 or 2 degrees Fahrenheit for 2 to 3 days. Infants, adults and immunocompromised people are at risk for more severe disease and have a higher incidence of complication. Severe complication caused by the varicella include cerebral ataxia, encephalitis, viral pneumonia and hemorrhagic condition. Full recovery generally occurs within weeks to months. Herpes zoster. It is also known as shingles. It results from the reactivation of the endogenous latent Varicella zoster infection within the secondary ganglia. People with the herpes zoster most commonly have a rash in one or two adjacent dermatoids. This rash most commonly appears on the trunk along a thoracic dermatode. This rash is usually painful, itchy or tingle. It develops into the cluster of vesicles. New vesicles continue to form over 3 to 5 days and progressively dry and crust over. They usually heal in 2 or 4 weeks. There may be permanent pigmentation changes and scarring on the skin. The complications in the herpes zoster infection include bacterial superinfection of the lesions, cranial and peripheral nerve palsies and vesicular involvement such as meningoencephalitis, pneumonitis, hepatitis and acute renal disease. Epidemiology of Varicella zoster virus. Varicella occurs throughout the year in the temperate region, but the incidence typically peaks in the month of March through May. Varicella is one of the classic diseases of childhood with the highest prevalence occurring in 4 to 10 years old age group. Chickenpox. 95% of the people is infected by the age of 20 years. Annual incidence in the United States is by 4 million cases. Approximately 11,000 hospital admissions are newly epidemiology. Approximately 100 deaths occur within a year. Substantial decrease in the hospitalization and the deaths. Shingles. Annual incidence in the United States is by 1.2 million cases. Approximately 30% of the population will experience herpes zoster during their lifetime. It mainly occurs only in the individual previously affected with the chickenpox. Lab diagnosis of Varicella zoster virus are direct detection method includes microscopy, cytology, electron microscopy, immunofluorescence cytology. It It is the smear of the scrapings in the base of the lesions which reveal characteristic multinucleate giant cells, which is also known as T-Zang cells. In electron microscopy, the herpes simplex virus particles can be seen in fluid taken from the early vesicles of either varicella or zoster. They cannot differentiate between herpes simplex virus or varicella zoster virus. Immunofluorescence cytology. It is the smear of the base of the lesion which can be examined by the immunofluorescence cytology in the case of herpes simplex virus. This technique is more sensitive than electron microscopy, but it includes more labor intensive and requires a greater technical expertise. Molecular methods for varicella zoster virus. PCR assays for varicella zoster virus are available and have been reported to be in the use of diagnosis for varicella zoster meningoencephalitis from cerebrospinal fluid specimens. Virus isolation. Virus culture in human fibroblasts are used in most of the laboratories. Vesical fluids and scrapings from the base of the fresh lesions are the most suitable specimens. CPE produced by the varicella zoster virus reveals typical ballooning and fusion. Immunofluorescence of the cell sheet by monoclonal antibodies is the method of choice for identification. Virus isolation for varicella zoster virus is rarely carried out because of the long length of time required for the result to be available. Serological test includes primary varicella infection can be reliably carried out by using paired acute and convalescent sera. Detection of the varicella zoster virus in specific IgM can be determined by immunofluorescence and capture radial immunoassay or enzyme immunoassay. Other tests include site complement fixation test and latent agglutination. Prevention. Preventing varicella in healthcare settings is done by the following standard precautions: airborne precautions, negative airflow rooms, and contact precautions until lesions are dry and crusted. The best preventive measure for chickenpox is the chickenpox virus vaccine. This vaccine is a live attenuated vaccine and administered subcutaneously. 2 doses of the vaccines are about 90% effective at preventing chickenpox. Dr. Michaki Takahashi developed the first chickenpox vaccine. Treatment. Varicella zoster virus is sensitive to acovir and its licensed treatment procedure for chickenpox. Other antiviral medications that may also work against chickenpox include valociclovir or famiclovir. Convalescent pooled serum containing varicella zoster immunoglobulin gives passive protection in immunocompromised children exposed to infection. However, it cannot be considered as an effective treatment. Thank you everyone.